So, good afternoon, all the delegates and the seniors present here. So, at the outset, thanks the organizers of the MODY for inviting me as a speaker here, and thanks the chairperson sir for the kind introduction. So, as I've given the topic, the diabetes in young. So, this year the MODY theme is to breaking the barriers and bridging the gaps. Because we are really concerned about the diabetes burden that every day we are dealing with in our practice. The number of patients are actually growing, and definitely the proportion of the young diabetic patients, that's also very huge in number. The last week, if I have not seen less than 100 patients with diabetes, then definitely I have seen at least 10 or 15 the young diabetic patients. Now, what is the theoretical definition of the young diabetes? It's in book, the less than 35 years of age has been defined, but still, in the last week, if I'm not wrong, I have at least 3 or 4 patients who are 7 years, 8 years, 12 years, 15 years of age, presenting with the poor glycemic control with a huge diabetes burden. So definitely, when I have requested by Dr. Vishwas to choose a topic on diabetes, definitely I think this is the bridge that we have to at least tackle, how to identify the cause of diabetes in the young and how to, in a proper way, to settle the issue with the young diabetes. So I will go a few of the cases at the same time. So as we all know from our student life, the young diabetes are mainly type 1 diabetes, because a child is presenting with around 12-15 years of age, maybe with a very poor glycemic control, with the high osmosis symptoms. So these patients have a type 1 diabetes, whereas a 45 year, 50 years of diabetic individual who are presenting there is type 2 diabetes. That was been taught in our student time. So type 1 diabetes definitely, the highest incidence is mostly in 5 years till adolescence, whereas the antibodies can be present, whether it's a V measure anti-GAD65 antibody, anti-IA, anti-IA2, anti-ZN8. But definitely certain population of type 1 diabetes who's idiopathic have antibody negative, and that is the term we term as antibody positive as type 1A, whereas type 1B who is antibody negative. Though there is no familial predisposition of the type 1 diabetes, but there are studies that shows that in families, particularly the twin of type 1 diabetes, have a very high chance of getting type 1 diabetes, and majority of more than 85% newly detected type 1 patients are actually sporadic. Definitely, it is not only the type 2 diabetes, but even in the type 1 diabetes, it is the capital in the world. We can see the number of incidents per thousands. It's almost 24 in India. It's the highest in all the other countries compared to the Caucasian population at the same time. Whereas the number of children adolescents with type 1 diabetes in thousands is almost 229.9 in India as per compared to the other countries. So definitely, that is a very, the tip of the iceberg, we can say. The majority of the patients till date, they are not getting the proper diagnosis of type 1 diabetes. So coming to the registry that has been found in 2016 data, where type 1 diabetes in 63.9% of the cases, whereas the type 2 diabetes is 25.3 in the young diabetic, the cohort. But what is the situation? And after a few years, there is a study by Dr. Shao. There is a heterogeneity in the etiology of diabetes mellitus in young adults. It's a prospective study, and the data published in 3 years after the 2016 statistics, 2019 data, where we can get almost equal percent of type 1 and type 2 diabetes. So there is definitely the type 2 diabetes even in the young individuals are growing, and that is the concern we have, because the type 2 diabetes definitely can prevent by lifestyle modification in majority. That is why I actually plea all the delegates who present here, all the young individuals who are obese or overweight or family history of diabetes, definitely the lifestyle modification, whatever be the reason the patient is attending in your clinic, maybe because of fever, maybe because of diarrhea, maybe because of some infection, but still you encourage the patients to at least get the loss of diet, exercise proper, weight loss, because of the prevention of type 2 diabetes. Nowadays we actually celebrate the pre-diabetes day. So the identification of the pre-diabetes and diabetes is a very important issue, and that's why at least we can delay the capitalism of India in 2040 that's been proposed for type 2 diabetes that is already reached even nowadays. Out of this 18 to 35 years of the 105 Indian adults, apart from type 1 and type 2 diabetes, we have at least 15% patients who have the MODY, 2% patients who have MODY, and mitochondrial diabetes is around 1%. So these are typical of a young adult who has recently presented with a 12-year boy, the osmolar symptoms. The father has diabetes. Patients have poor glycemic control, HbA1c of 10.1%, fasting 206, postprandial 492. It is a strategy we have to, at least as the patient has osmolar symptoms, we have to start with the multiple subcutaneous dose of insulin. Then we measure, after glycemic control, we measure the stimulated C-peptide level to differentiate, and definitely the patient is having a good the C-peptide level, that means the insulin reserve, that indicates the patient is not typical candidate of type 1 diabetes, rather the patient have type 2 diabetes. If you can see the picture, this indicates the black, the pigmentation, this indicates the acanthosis nigricans, which is a sign of insulin resistance, and that's a categorization. I think the patient have grade 3 or grade 4 acanthosis nigricans. So we are also getting the patients like both the parents have diabetes and the boy or the girl have a very, the age of presentation is around 15 years or less than 15 years, that is. That means the patient who have a very strong family history, even the next generation can have the diabetes maybe very early from 10 to 20 years of age. So I have started the patient with metformin 1 gram, and the patient have a very good glycemic control after 3 or 6 months of the therapy initiation. So this is the paper that is published in BMC, endocrine disorder, where Dr. Pradeep Kumar shows the result that the prevalence of prediabetes and diabetes was around 12.3% and 8.4% among the adolescent boys and girls in India, and the body mass index and subscapular skin fold thickness were the two most important predictor for the prediabetes diabetes among the adolescents. The physical activity shows a negative association with the prediabetes and diabetes. That means more of the sedentary activities with the improper diet that leads to this condition of the metabolic syndrome. Now coming to the another part of the young diabetes, this is a 22-year male student recently developed the fatigue, the change in visual acuity, there were no true osmolar symptoms. Both the father and grandfather have developed diabetes, and father had initiated around 21 years of age and grandfather 24. There is no drug history, no addiction, maintains a healthy lifestyle. So what is the possibility of diabetes in this patient? The patient have a BMI of 23.3, there is no acanthosis or skin tags, that means there is no signs of insulin resistance. There is no features suggestive of other endocrinopathies, blood pressure is well normal, and other system examination is normal. So the lab reports again, HbA1c 7.8%, fasting 128, postprandial with glucose tolerance is 212, triglyceride is normal, urine ketones absent, C-peptide shows a good insulin reserve of 3, and the USG there is no pancreatic structure anomaly, but few renal cysts present. So diabetes in young with renal cyst with a strong family history, particularly less than 25 years of age in 3 generations, that indicates it can be a case of MODY. So young diabetes, definitely that goes in favor, but we have type 2 diabetes also present in a very young age. 3 generations, the patient's father, grandfather all affected, and the laboratory investigation confirms it's a diabetes, so that's why we can stand. Look, definitely we can do the genetic analysis. It is not widely available. I think I've sent majority of the patient sample to CMC below under Dr. Neha Thomas, who actually do the study on the MODY, and we can get the result, which type of MODY the patient have. What are the features of this maturity onset diabetes of young? It's autosomal dominant inheritance. At least one of the family members should have diagnosed the diabetes as less than 25 years of age. Autoantibodies are negative, and absence of ketosis. Again, the correlation of hyperglycemia for at least 2 years without insulin is an important one for diagnosis. So how to differentiate MODY with type 1 diabetes? C-peptide is normal in MODY, all the antibodies are negative. And for type 2 diabetes to differentiate, though it's a very similar history of type 2 diabetes, but young age of onset can be one of the predictor. Generations of the family, this is a family history is very important. At the same time, the genetic study that we can do to identify MODYs, this is we can get in theory. So the different the mutations in present HNF1 glucokinase HNF4 alpha. MODY3 is typically the most in number. Though this is a study which high prevalence of this MODY among the Indian, that is by Dr. V. Mahan, which shows that almost 4.8% the consecutive patients had the MODY and 27% had definite autosomal dominant inheritance. So why the MODY is different in India compared to that of the European population? Because there is 152 clinically diagnosed MODY patients from southern India, mostly from CMC below, and the relevant variants in previously described genes is around 15%. MODY3, that is the defect in HNF1 alpha, is the most frequent one. Second common is the MODY12, that is the defect in ABCC8 gene. The GCK alteration, there is less than 1% of the patient sample, and European population up to 80% of the patients carry the variants of HNF1A and the glucokinase. So here another study that in clinical characteristics of the MODY due to molecular anomalies of HNF gene that shows 40% were more than 25 years old. So the classical teaching that the people with MODY, the MODY will diagnosed of less than 25 years of age, but that is not true even for the 40% of the patients. Only 50% of the patients had 3 generations of family history. So we may not get all the the 3 generations even in the 50% of the MODY population. And even some of the MODY patients have a BMI of more than 25 that can be overweight or obese, that can confuse with the data from type 2 diabetes. So this is another story of a 26-year male who is from Odisha and diabetes for the last 3 years duration, treated with glimepiride, metformin and pioglitazone in full dose, poor glycemic control. The patient is too much cachectic, and there's history also says that from since childhood the patient has recurrent pain abdomen. Occasionally there is the stool is looking fatty, that is steatorrhea, and there is no still family history of diabetes in this patient. So this is the extra abdomen that shows, we can see the calcification in the pancreatic region. So the diagnosis is the fibrocystic disease of pancreas, that is FCPD. This is another very important diagnosis of the young diabetes that is usually present, and particularly the Indians very much, because it's a tropical country specific disease. And the fibrocalciferous disease of pancreas is around 0.3% of the self-reported diabetes in Chennai, has been studied. In Kerala, it's 1 in 1,000 in general population that has been diagnosed with this, the cause of diabetes, that is FCPD. And Tamil Nadu and Odisha has also reported high prevalence of the disease of FCPD. So these are the diagnostic criteria of FCPD. The patient should be from a tropical country. The diabetes should have been diagnosed from the evidence of chronic pancreatitis must be present, that is a pancreatic calculi on abdominal X-ray, or at least 3 of the following, that is abnormal pancreatic morphology on the ultrasonography of the CT scan. We have to mention that US cannot detect the pancreatic anomaly or the calcification in many of the patients, so CT scan can manage if there is a high clinical suspicion. Recurrent pain abdomen since the childhood, steatorrhea, abnormal pancreatic function test, and the other cause of chronic pancreatitis like alcoholism has to be looked at. So this is the difference in nutshell, how to differentiate the alcoholic chronic pancreatitis versus tropical chronic pancreatitis. I am not going in details of it, it's widely available in the internet and the theory books. There's a very important thing that these are also very confusing many times with the FCPD with the type 2 diabetes, because many of the symptoms or the signs can be present in FCPD also, like positive family history in FCPD present in almost 50% of the patients. The signs of insulin resistance like skin tags or acanthosis nigricans can be present in 7.3 to 4.8% respectively. Even the osmolar symptoms can be present in almost 42.7%. This is very much confusing for the type 1 diabetes as differential. The patient can have the pancreatic calculi in almost 100% of the patients that's too much diagnostic for this FCPD. This is another, the young lady who is actually presented with the dysmorphism and the severe acanthosis nigricans, what we can see in the underarms. But I think these are the cases has already been discussed by Dr. Shunitra, because this is the case of Rabson-Mendel syndrome, where we can get the high the insulin resistance. So So this is the spectrum of the insulin resistance, so the residual insulin receptor function from 0 to 50%, where Downer syndrome, Rapson-Mendel syndrome, and type A insulin resistance is the majority. So they present with a linear growth retardation, soft tissue overgrowth, hyperandrogenism, particularly the hirsutism, and amenorrhea, insulin resistance, diabetes mellitus, and impaired development of skeletal muscle or adipose tissue. So mostly they are thin. Coming to the lady, actually presented a few years back in our OPD at Medical College. As the 15 years the lady was presented with new onset of diabetes, along with the patient have oligomenorrhea, mild hirsutism, hypertension, and proximal myopathy, and there is no family history of diabetes. You can see the puffy face of the patient. And this is the imaging that shows there is the adrenal lesion, suggestive of adrenal tumor, so it's a case of Cushing's syndrome. So again, the young diabetes, so we have to find out if there is a clinical suspicion that endocrine related diabetes causes like Cushing's syndrome. That's very important. And definitely here, if we get a patient of suspected Cushing's syndrome, we have to first rule out the exogenous Cushing, that is the improper administration of high dose corticosteroid for long duration, because this is very common in our population, particularly in the rural practice for different reasons. So first, rule out the exogenous Cushing by doing the morning cortisol level, and then we can proceed if there is normal morning cortisol or high side of the morning cortisol, we can proceed for endogenous Cushing, that by doing at least 1 milligram overnight dexamethasone separation test followed by the confirmatory tests. This is another patient who is 26 years with new onset diabetes. There is family history A negative. And we can see the clinical features of the dental malocclusion, the patient has macroglossia, and patient has skin tags, and this is the imaging, pituitary imaging shows there is a pituitary adenoma, macroadenoma, and the patient have clinically acromegaly. So this is another very important cause of endocrine cause of diabetes in young. So apart from the Cushing syndrome, if there is a patient have the very deteriorating course of the diabetes, hypertension, skin tag, and the acral enlargement, headache, and the sweating, obstructive sleep apnea, severe joint pain. So these are all the indicators the patient can have somatostatinoma, that is the acromegaly. So these are the rarer causes, but definitely we have to at least understand, as per the Dr. Shunetra's talk, so the obesity in childhood, where we can have the diabetes as a part of the total syndrome process. So this is a 14-year-old boy, the painful maturation, developmental delay, early onset hyperphagia and hypogonadism. And this has been a case report from NRS Medical College by Dr. Krishna Shankarji. It's a case of Prader-Willi syndrome. I am not discussing it because already we have discussed this in Dr. Mondo's talk. Again, this is a Bardet-Biedl syndrome, which is another child with obesity with diabetes and hypogonadism. So this is the diabetes and
less than 2 minutes.
Yeah, okay. Just I will take maybe 2 or 3 minutes actually. This is very important part of the talk. So retinitis pigmentosa, so we have to find out whether there is a child with obesity and there is no obesity, and according to that we can categorize Bardet-Biedl, Alström, Bunchier, and Dittmond syndrome. So history taking is very important, starting from age of onset, temporal presentation, pain abdomen, weight gain, oligomenorrhea, hirsutism, deafness, myopathy. So all we have to at least consider for the history part of the young diabetes. The family history is very important. Though type 2 diabetes in 80%, we can get type 1 diabetes in 2 to 4% family history, MODY in 90%, and maternal inheritance also very important one. This is the maternal inheritance, where we can get the maternal inherited diabetes and deafness. Apart, there is a mitochondrial the disease transmission. Again, the acanthosis, lipodystrophy, myopathy, hypercortisolism is important. In examination, the fundus, we have to go for retinitis pigmentosa and optic atrophy. The important thing in investigation for triglyceride, low HDL, that goes in favor of type 2 diabetes, whereas the SCOT, liver function test, TRITEX abdomen, and USG, we can get as part of the treatment. The C-peptide assessment is very important, which can be done the basal or stimulated value, and antibodies for type 1 diabetes and genomic sequencing are also very important for overweight diabetes in young and the MODYs. Now for C-peptide, there are different cutoffs for the C-peptide. For fasting C-peptide, usually less than 0.3, and stimulated C-peptide of less than 0.3 is very important for type 1 diabetes as insulin deficiency. There are different cutoffs of C-peptide assessment, but this is the standard C-peptide the levels we can consider as for insulin deficiency. Though a study from NRS Medical College by my batchmate Dr. Srinath shows that the C-peptide assessment after the glucose stimulation with the 75 gram oral glucose is a very easy technique for assessment of the postprandial C-peptide level, which is instead we do with a meal test, which is a very complex procedure we can't do in routine practice. So this is in a nutshell how to proceed for diabetes in young. So we have to at least give the stress for the family history, then whether the 3 generation present or not, whether ketonuria present or not, then we can go for the simple imaging techniques and other issues with the C-peptide level for proper assessment in diabetes. So with this, I give the special thanks to the Department of Endocrinology and RSMCH, Dr. Nilanjan Chandra sir and Dr. Shomi Goswami sir, my teachers, my patients. Thank you for the patience here.